Mantas Trakymas with the topic contemporary multiparametric MRI based focal prostate cancer ablative therapy. So you prepared to speak?
Yes, thank you, Algirdas, for introduction. Actually, focal prostate treatment is I was thinking many years ago that it's a possibility to do that, but uh, actually it's quite tricky thing. You always at first you have to see the tumor, uh, and only with MRI we started to see the tumor. Um, Actually, whole gland treatment is currently is a standard of care treatment. Uh, either it's a radical prostatectomy or radiotherapy. That could be brachytherapy or external B radiation. Uh, However, all these treatments have they are effective. They treat the whole prostate gland, uh, but these modalities also affect the urinary sphincter, the neurovascular bundle, bowels, the bladder, and we have these so-called post treatment complications that usually could be seen not right away. Sometimes they appear later. It depends on the treatment modality, but still we have a lot of these complications, and that's why the treatment of entire prostate gland is um always looks like that we need to do less harm for the prostate, especially if we have a very small lesion. It's if it's localized only in one part of the prostate, and that's why we saw the prostate cryotherapy tries. We try to do the whole prostate cryoablation, but still we had a lot of complications of that treatment. Uh, the focal treatment of prostate can be defined as treatment of specific areas of prostate uh, in order to minimize treatment relation morbidity, and that became possible only when we started to see the cancer. When the MRI and multiparametric MRI appeared in our minds, in our experience, and before the multiparametric MRI era, we only knew that there is a cancer in the prostate, but we were not able to show exactly where it is. That's why the whole prostate treatment was the standard of care, and still it is the standard of care. But as also we know that there is when we have a low risk cancer that is Gleason 3+3. Usually we do not see this cancer on MRI, and that's why there is a question if we really need to treat Gleason 3+3 tumors that are not visible, and all the trials that were carried on for the patients who are on active surveillance with a cancer, with a clinically insignificant cancer. They were treated with focal therapy, but I'm not sure what was treated there if we actually couldn't see that cancer in the prostate, even with MRI. So all these, I would say it's a pseudo treatment, and it should not be proceed with this nowadays modern MRI imaging. So the recent data from the PROTECT trial showed that actually there is no big difference in 10 years cancer-specific survival between active surveillance, radical prostatectomy, and external beam radiotherapy in low and intermediate risk prostate cancer. So there is some problems with active surveillance, that they have more metastasis, and from that we can think that we could help for those people who are ill with um, prostate cancer and could be followed up. We can help them to treat focally the tumors that are seen on MRI. And if this treatment doesn't make more harm than other standard of care treatment options, so we can say that we help these people, and this is rational to try to use this. It's written that in the literature that patients with a small Gleason 7 ISUP2 lesion might be better candidates for local treatment. Not the Gleason 6, but Gleason more than 6. Also, so far this group has been really investigated and published trials, and I think we need to do these trials. What is focal treatment? It could be different ablation methods. As I said, cryoablation. It could be high-intensity focused ultrasound. It could be a photodynamic therapy. Also, electroporation is very, very good choice to treat even tumors after the local progression after radiotherapy. Also, laser ablation and focal radiotherapy as brachytherapy or stereotactic external beam radiotherapy. All these modalities could be used in focal manner, and we could sometimes find better solution while choosing between these different modalities. When you have a wide spectrum of choices, you can choose, and it's better to find the best solution. Actually, the concept of focal therapy or focal ablation can only provide long-term benefit to patients if it satisfies some special criteria, some special requirements. It should be survival efficacy at least equivalent to standard of care. It should give less complications and less side effects compared with this standard of care. We must have reliable follow-up of remaining prostatic tissue that was not treated with ablation or other modalities. And also, as we were talking about the one case after the radiotherapy, that secondary or salvage treatment that could be used later if something is not good with that treatment modality should not be impaired by the primary focal therapy. If we could satisfy all these requirements, we can go further with the focal therapy. There was actually, we don't have a lot. There is a lot of papers about focal treatment, but still we don't have good results. I mean, not good results, but long-term results of all these focal therapies, because they started with maybe MRI pirates beginning in the beginning, but still now it's going on many trials, and usually all these recommendations. They are done in the panel discussion when you do some consensus or something like that. And this is one consensus from 2017. What they highlighted that still the multiparametric magnetic resonance imaging is a standard imaging tool for patient selection when you want to try to use the focal therapy. So as I said, we need good MRI. If we have a lesion, we need to do the biopsy of that lesion to define what's the histology of that tumor. In addition, we also need to do the systematic biopsy to check if there is only one lesion or maybe there are some more lesions that should be treated in other way. Also, as I said, it's better to treat not low risk cancer because usually we don't see, but of course it's good if we can see the tumor on MRI, we can treat it even if it's 3+3 cancer. But still, the more aggressive cancers are better seen on MRI, and if it's not big tumor and we could safely treat it, we can treat it. So ISUP 2 plus is the most suitable tumors for focal therapy. The size 1.5 millimeters, 3 millimeters, and so on is discussable thing. I think the smaller cancer is the easier to do the focal therapy for that, but sometimes the tumor chooses the patient, not the patient tumors, and we can't decide the size of concrete on the particular patient. So, and one thing that Gleason 3+3 at one core of 1 millimeter is acceptable in the untreated area. So we can have some Gleason 3+3 small tumors in the other places, but it should be very small. Preservation of sexual function is an important goal, but lack of erectile function should not exclude a patient from focal therapy. So actually, we can treat the patient without erectile function in focal manner, because not only erectile function is the main. And this is the new reviews paper from 2022. There is new findings, recent findings that these panel recommendations of experts every year become less conservative, and experience with all the modalities for focal therapy grows. New modalities are introduced for focal therapies, and now we are in the position to offer the personalized treatment pathway for each therapy modality. And what is ideal case for focal therapy? It should be the lesion that is visible on MRI. Usually it's Pirate score 3 or more. Actually, it should be with histological verification. And as you see, as I said before, that it should be Gleason maybe it's Gleason group, ISUP group 2 or 3. It's more aggressive tumors, not Gleason 3+3, Gleason 6 group. If we have the insignificant disease in the non-target area, it could be, but it's better not to have it. And even multifocal disease can also be selectively treated if we have 2 or 3 tumors in good position and in favorable localization. We could treat even more tumors than one. Salvage focal ablation is an attractive treatment option for recurrence after the radiation therapy, or other focal therapy failure cases. So actually, we should go further with the focal therapy and to find the best solutions for the patients, especially if, the patients who are older, who are suggested with active surveillance. Sometimes even treatment of that visible on MRI tumor helps them to think that they are treated and can psychologically be more stronger. What kinds of focal prostate ablation we can do? We can do really targeted or focal ablation of the tumor. Usually we need to do a little bit more ablation than it's visible because of tumor spread around that is not visible. It's better to have the 1 centimeter around the visible tumor margins. It could be hemiablation. It's also a focal treatment. The more sometimes is better, but if you can do it safely. And sometimes we can do even zonal ablation, or when the tumors are ablated in half of the prostate and a little bit from the other side of the prostate. But as I showed you, the mapping biopsy should be done to be sure that in other places that are not going to be ablated, there is no clinically significant tumors. So what are the insights of all my talk? That focal therapy shouldn't be used for really low risk cancer. It's a new paradigm, because you can't treat the tumor that you can't see. Otherwise, we go back to 10 years ago when we didn't have the MRI imaging, and we didn't trust that. Focal therapy would be an ideal approach for small tumors, small volume cancers of intermediate or high grade, if they could be accurately targeted and treated completely, leaving areas of indolent cancer that do not pose a biological threat to be actively monitored as with active surveillance. So thank you for listening. Actually, I don't see the questions in the audience. Maybe
Thank you very much.
Algirdas, you have some questions.
Thinking about that, so focal therapy, yes, basically it's very important. I think it will be used in our center in near time, yes. So you have experience. You made procedures. Can you a bit share with your experience about that? Maybe some issues for that.
Yeah, actually, we did one case some years ago, and it was okay. The only problem for all these therapies in prostate that we need a lot of time of follow up. We need 10 years to see the results, and even after 10 years, usually the result of efficacy should be the same, because we know that even with active surveillance, without any treatment, the patients could survive in the same percentage as after the radical treatment. So the main thing, I think, that these focal treatments should be safe, and not complicating the quality of life of the patient. So any option of focal treatment, as I said, maybe even psychological thing for the patient, that he was, because sometimes when you put the patient to say that, okay, you have cancer, but we won't treat you, we will follow up, sometimes it demotivates the patient. He thinks, these doctors, they I'm old, and these doctors, they don't want to treat me. But he can't understand that we want to help him to be more to live more comfortably, uh, to save him from all these complications of radical treatment. And eh, yes, it's quite complicated to start all this.
Uh, I see no questions for the virtual audience, so I think we finished with this topic. So thank you again very much.